A very good evening to you all. Thank you very much indeed for joining us for this evening's session, which is about procurement for value. And this is a very warm welcome from Wales to wherever you're joining us from this evening. And we've got a fantastic panel for you. I think it's going to be a really great session, and we're looking forward to a very lively question and answer session towards the end. I'm Hamish Lang. I'm a professor in the School of Management at Swansea University, and there I lead a programme of research and education in value-based healthcare. We work very closely in that programme with the life science industry, particularly with colleagues in Pfizer in the UK and globally. And we're really working to try and understand how to apply value-based healthcare to medicines and to ATMPs, gene therapies. If you are going to have a value-based healthcare system, and as you will know, if you didn't already, that Wales is very ambitious in this respect, and in many respects is leading the way, one of the leading regions or countries in the world to be implementing value-based healthcare. But if you want to do that across a whole system, you can't just focus on single interventions. You have to look at long-term conditions and pathways of care. And you can't leave out the procurement of goods, of services, of devices and of medicines. That you really need all the levers to be working in a common way to deliver a value-based approach. And that's why this session this evening is so important. Some of you will have taken part in the session on Monday evening, and if you like, that was the kind of why. Why should the life science sector work with health systems around the world to adopt value-based healthcare? Why from your perspective? This evening session is much more about the what and the how, getting into the weeds a bit on some of the challenges and some of the critical steps to make it successful. And I would say at this point that we certainly don't think we have all the answers. In fact, quite the opposite. We think we all need to learn together if we are going to do value-based healthcare procurement. We're going to do it well, we're going to do it fairly, and we're going to do it so that the real winner is the patient. And as a byproduct, the system and the company will win as well. So we've assembled a great panel who will talk to you from different perspectives, and I'm very grateful to them all for joining us. I'd just like to remind you, if I could, before we go to our first speaker, if you wouldn't you'd be so kind as to mute your microphone and to turn off your camera, and to keep it like that throughout. If you have any questions that arise during presentations, please do post those in the chat, and we'll do our very best to get to them in the Q&A. We also have one or two questions that people have already asked in advance. As you know, there was a chance to do that. So without further ado then, I'd like, if I could, to pass over to Dr. Rupert Dunbar-Rees. Rupert is the Chief Executive of Outcome-Based Healthcare, and he's going to talk to you from his perspective and experience. Thank you, Rupert.
Thank you, Hamish. Good evening, everyone. So I thought I would just share a few perspectives on some of the work that I've been involved with over the last few years. I've been working in value-based commissioning, outcomes-based approaches to healthcare for probably over a decade now, and most recently over the course of the last year I've been working with working in Wales with Swansea University colleagues, Pfizer colleagues and NHS Wales NWIS colleagues. Before that I was before that 10 years ago I was I worked in the commercial team at the Department of Health in London, working in procurement almost exclusively over the sort of a 2 or 3 year period on large clinical services procurements that were being done at the time centrally. And before that, I was a GP partner in Scotland for 5 years. And before that, I was a hospital doctor in and around London for 5 years. So I guess I've kind of worked in most parts of the UK. I've not worked in Northern Ireland yet. But and so I suppose I've seen perspectives on value from all of those areas. And these days, I run an organisation called Outcomes-Based Healthcare. We're an organisation based currently in London, and we're a health analytics organisation principally. And our mission is to focus on changing the way that healthcare is reimbursed and paid for to better align with what matters most to patients and to align better with best clinical practice, because just too often it just doesn't align with that under existing payment and reimbursement mechanisms. I was introduced to value 10 years ago or so, introduced to the work of Michael Porter in Harvard Business School, and I having heard a lot of the value principles, I thought that sounds great. Can we translate it into a UK context? This is really quite different in the UK. Things are quite different in the UK. And over the last 10 years, I suppose I rapidly found that the biggest gap to implementation in a UK kind of context was health outcomes measurement. And I felt that there's quite a lot of advice and support around contracting and finance, and but I found outcomes measurements there to be a real gap in capability in the UK context. And I suppose structurally, there are reasons for that. One is that, as Hamish said at the beginning, outcomes, we're often measuring outcomes over a full care pathway. It's not a single intervention many times. Many times you've got lots of things all happening at the same time along the care pathway. And and in the UK, that means many touch points, and that means touch points which span different care settings. And outcomes data, unfortunately, also spans different care settings. And so now I find myself spending a lot of my time working on developing and interrogating linked longitudinal data sets which span those different care settings. And I spend a lot of time on information governance, much more than I ever thought I would. Where has that sort of led to? So I guess most recently, apart from the work in Wales, which we'll hear more about in due course, that's meant work with NHS England to develop a population segmentation data set which provides condition registries for over 60 million people in England, and that's sort of forming the backbone for outcomes measurement over there. And I've also, it all started a lot smaller than that, working with local care systems, really working with the willing, to use Michael Porter's terminology. People, healthcare systems, health systems looking to do something different, looking to focus on outcomes and not just activity and care processes. And so we work with a range of different health systems in England as well, monitoring outcomes for different population groups, different population segments, different pathways, different conditions, using linked data spanning different care settings. So in Wales, I'm going to leave Jess, a subsequent speaker, Jess Burton from Pfizer, to cover some of the work we're doing in Wales, but we're working with NHS Wales, NWIS, Swansea University and Pfizer on a learning and development project around what we can learn about what's needed to develop outcome-based agreements in breast cancer, but I won't steal Jess's thunder on that one. So I suppose I was going to share 2 or 3 perspectives before handing over to the next speaker over those 10 years. So my first sort of insight or perspective was around taking value principles and trying to map those to a UK context. And my feeling is that we can't only start measuring outcomes once people have already developed a significant health condition, and I think Samir Gray and others have been instrumental in pointing this out in terms of looking upstream. And if we are to really improve population health, then that has to mean the population. So we have to look at those who are currently healthy, and basically value starts there. We found a lot of time in our work that we started measurement of outcomes once someone had already been diagnosed with diabetes in the first few years of our organisation, or another long-term condition, or another adverse health state. But actually, there is plenty that can be done in before that even occurs. And and so I'm delighted to see that in Wales, the movements around prudent healthcare and Wales really has seemed to have taken this aspect to heart, and it's very encouraging to see. From our perspective, what that's led to for our organisation is really thinking very hard about upstream outcomes, so outcomes for the healthy population, and over the last, or healthy, currently well population. And over the last 4 or 5 years, we've been working on a suite of outcome measures called HealthSpan, which measures the proportion of population level outcomes, which measure the proportion of life spent in good health. We can talk about that a bit later if that's relevant. I suppose my final point on this was often in outcomes measurement, particularly in relation to personal outcomes or PROMs, we're measuring people's responses around how they feel about the presence of health and generating health, well-being, confidence, ability to manage their condition, and so on. The other side of that sort of outcomes coin is really oftentimes we're measuring the absence of ill health, so the avoidance of heart attacks, the avoidance of strokes, things like that, adverse consequences. And I suppose what I'm going to sort of leave on a bit of a challenge, because if we're sort of measuring the absence of bad things that we don't want to happen, then that's going to lead to challenges both in measurement, and this is a challenge we grapple with on a daily basis, but also in terms of reimbursement. It's very hard to construct payment and reimbursement and procurement mechanisms that sort of reimburse things that are not happening. So I was going to sort of leave at that point and hand over to the next speaker, who is Andy Smallwood from NHS Wales Shared Services Partnership. Thank you.
Thanks, Rufus. I'm more recent to value-based healthcare than yourself. I'm probably about 4 years in, following working with Del Carhill out of Van Bevan and meeting Dr. Sally Lewis and Alan Brace on to talk about the topic. And I suppose from my perspective, it really resonated in an odd way. My career started 30 odd years ago as an engineering buyer, and procurement wasn't just about buying things, it was in the partnership space, because production efficiency and production quality was key to what we did, and we worked very closely with suppliers. Lots of diagnostics built around the way that their products were used. So we were getting that feedback constantly, and we were working with the suppliers to improve, I suppose, similar outcomes, but that was to do with quality and product, the quality of the product and the efficiency. When I joined the NHS 23 years ago, I suppose I became separated from the actual use of the product, and the NHS at the time was all around specifications, closed tenders, and you were almost devolved from the ultimate decision and use of the products. I was fortunate to land within the orthopaedic space not long after joining the NHS, and I spent most of my last 23 years working within orthopaedics procurement. I am very proud of two things. One, I'm the longest serving member of the National Joint Registry Steering Committee, and secondly, I'm the founder of the Orthopaedic Data Evaluation Panel, which I was glad to hear that Ruth Griffiths referenced on Monday evening from Zimmer as a good thing, and I agree with her with regards to it's a good thing at a point. I think what we did, and what we still do with regards to that, is we look at the evidence with regards to the survivorship of orthopedic implants, but we look at it in the context of when the patient had it implanted and when they had it removed, which is quite blunt metric. So you know how long the patient actually had a joint replacement, but you don't know how they dealt with it, how they coped with it during that time. We've also, well documented, we have some waiting lists within the NHS, so you actually don't get to know exactly when that prosthesis failed as well. So I think from ODEP at point in time, I think this is still something that I'm pretty proud of. But I think that the discussion and value-based healthcare really resonates as to how that can be improved upon, because we don't actually get to see how the patients were impacted by that surgical procedure. The PROMs are being added into the NJR, and there's a session in this program tomorrow around the knee dashboard, so I recommend that to people as well. But from a procurement perspective, within Wales, we're trying to embed a culture of value-based procurement and taking the procurement teams beyond the price of the product, beyond the specification of the product that's there just in a pure buying sense, and try to build in metrics that actually lend themselves to efficiency, efficacy, and outcomes. We've got our 3 Ps within our value-based procurement framework. So we focus on the product in a traditional way. We still buy consumables in procurement, and as such, we just need to make sure that the quality level is there and that the standards don't drop and that the patient outcome isn't negatively affected. And then we tender for price above that. For efficacy, we need to make sure that similarly that the patient outcomes is protected, that the system works better, and we have a better utilization of resources. And then the patient, which is the ultimate one, where you've heard a lot this week around the digital agenda, the more granular data we're able to capture with regards to outcomes. And we'll see a lot more procurements across Wales that are being built on that footing. So just last from me, Hamish mentioned early on that we haven't got all the answers for you. I wish I did, but if you've been following the whole week, you will have seen that that we're really being helped along our journey by all of the groundwork that's been put in, all of the data collection that's going on, that will help us work with industry, work with clinicians to have a common understanding of what our goals are. And hopefully we can continue to explore that over the rest of the programme. That's it from me for now. I'm going to hand over to Jess Burton from Pfizer.
Thank you, Andy. So thank you so much. I'm Jessica Burton. I'm the Director of Outcomes Innovation at Pfizer in the UK Health and Value team. And when we're thinking about what Lens Pharma is looking at for value-based healthcare, for us, it's patient outcomes. And actually, that's a shared lens with others on the care pathway. So I think it's actually quite critical for us to think about the common goal that we have with providers of healthcare and how pharma can work together with those along the care pathway. Because at the end of the day, what we're all striving to achieve is in fact enhancing and/or improving patient health outcomes. So by focusing on this shared goal together, it actually unites us in creating tools for procurement for value. And a bit tonight about outcomes-based agreements, as Rupert alluded to, and one such example that we're looking at. Now, what's really exciting is that actually, if we unite around this shared goal of enhancing and improving patient health outcomes, it actually moves us away from who wins, which is something that I'm frequently asked as a member of pharma, to everyone actually focusing on meeting this common goal. Because if we're meeting this common goal, all of us are winning and patients are winning, which is quite critical. Not only that, it actually enables us to shift the conversation to redefining a mutually beneficial definition of value. And I think what's quite critical, and that some of the other panelists have alluded to, is thinking about the multidimensionality that we could incorporate within this redefinition of value. So pairing clinical outcomes, which is frequently something that we look at, with patient priority outcomes, or the outcomes that matter most to patients. So by creating a more comprehensive understanding impact of a patient's daily life and the benefit of an intervention, we're able to think a little bit more holistically about value and have different conversations. And that's actually key to shifting the conversation away of paying by pill to paying for value. And it requires a different accountability on behalf of life sciences sector. And that was something that my colleague Emma Clifton Brown spoke to earlier this week on Monday. It reinforces a more system level approach, but it also requires leaning into the complexity a bit more. It's tough. We have to untangle then those challenges and barriers together. But that actually is a unique opportunity to have everyone at the table together to solve those tough challenges and to enact that with trust and transparency. as underpinning tenets of this new way of partnership. And that is actually how we've created Project Ideate. So this is a project that we are very excited to be working on with our NHS Wales colleagues. We also have the pleasure of working with Swansea University and outcomes-based healthcare. So what we're trying to do is effect a cross-functional or cross-organizational collaboration to transform future design and implementation of patient-centered outcomes-based agreements. And that's for medicines primarily. So how do we do this? How do we diverge onto the path less traveled? I would say there are a few key markers. We have to learn from the past. So that's where we started. We did a systematic analysis of outcomes-based agreements, the literature, anecdotes, to understand where we've come from. That then helps us target key areas of historical challenge, and thus we can emerge with a shared roadmap for success. So that sometimes is a bit abstract. So I'm a person who tries out different analogies. We'll see if this one works. But I'm going to use my kids as an example. They were drawing the other day, and they created a really amazing picture of a Tyrannosaurus Rex on a rainbow. And then they decided, actually, after creating this magnificent plan on paper, to enact it in real life. So they got a bunch of materials together, and they were going to build that rainbow bridge, put the Tyrannosaurus Rex on the rainbow bridge. Unfortunately, when they started to build that rainbow bridge, they discovered that the law of physics created some hiccups for them. And I think that that actually is a good parallel to us when we're thinking about outcomes-based agreements, as crazy as that sounds. Because on paper, we can be exceptional. We can try to implement that exceptional plan. And frequently, at least in the past, we've learned it can fall down. And perhaps then the outcomes-based agreement that we have designed together becomes a default discount or becomes a really traditional agreement that doesn't really reflect the true value of a medicine for a patient and for a system. So that's quite similar then to when operational readiness doesn't actually match up with the ambition of an outcomes-based agreement that's designed. So with this project, we decided, okay, let's get into the weeds. Let's design a project where we can jump backwards in time and we can use historical or retrospective data, design a hypothetical outcomes-based agreement, press play to see what works and what doesn't work. And it's within a safe environment, a low-risk learning environment. We'll use a computer model. And like I said, we'll use historical retrospective data. So that's actually what Ideate is looking to do. We're looking to dive deep, to get into the weeds, to get messy, to find the headaches, and co-create sustainable solutions for those key areas of historical challenges and barriers. And we have 5 buckets that we're targeting: data and information governance, the patient cohort and segmentation, outcomes measurement strategy, understanding different models of financial contracting, and finally, and perhaps most important, real-world implementation. So really truly understanding the pain points within the system. And we're doing this with information governance agreements in place. We've found ways to work together in this new model of partnership that's across organizations to ensure compliant data processing and to find, like I said, those novel solutions to some of these tough questions. And what we actually found is above all of those buckets was that partnership piece. That turns out to be the most important and first building block that we have to have when we're thinking about these challenges and solving them together. So we learn from the past, we leverage that learning, we go deep with Ideate to solve those challenges together, and then we walk through those steps and share that roadmap out. So this isn't something being done in secret. We're looking forward to sharing the output of this project with all the organizations and with you in the coming days, which is a unique opportunity for success. When you leverage those lessons learned, you solve some of those problems together, and then you have a dynamic solution that will evolve over time. So what I'll leave you with is build a rainbow bridge. The building blocks are dynamic and they will evolve over time as we learn more. And maybe you're going to have different materials than you thought you would. And that will be a bit different than bending the laws of physics. But perhaps that will lead to cutting edge data lakes. Perhaps that will lead to novel information governance agreements that will compliantly propel us toward delivering that shared goal of enhancing patient health outcomes. It requires a different mindset from partners across the care pathway, but it is achievable, and we're learning that in Wales. So with trust, we can show up differently with a creative team of experts from many diverse backgrounds, with transparent cross-organizational collaboration, and laying those building blocks together, we can enable success in our trajectory towards delivering that goal of improving patient health outcomes. And so it's been an incredibly humbling and inspiring journey. Looking forward to continuing to learn with the team. And just a quick shout out to the many amazing individuals who have contributed and continue to contribute to this at NHS Wales, especially our colleagues in the informatics service, Gareth John and Andy Warburton, Swansea University, our excellent facilitator this evening, Professor Lang, experts at our partner organization, Outcomes-Based Healthcare, including Dr. Dunbar-Rees, and the many, many Pfizer colleagues creating change, including the Outcomes Innovation Team and the excellent strategists, including Kate Halsby and Graciela de la Fuente. So with that, I am happy to hand over to Dee.
So good evening, everyone. My name is Dee Puckett. I'm Head of Health and Care Engagement at the Life Science Hub Wales. I'm also the Senior Lead for Value-Based Healthcare. I've actually worked in and across health, Welsh Government and UK policing for the last 24 years. And as everyone else has kind of said about their introduction to value, I guess I came at it slightly differently when I was actually interested in the victim outcome measurements in UK policing, and just really seeing how disconnected approaches can be due to processes and policy and the direct impact on people's personal lives and experiences. And then coming into health and coming into the Life Science Hub Wales, really looking at how working in partnership across industry, with academia, with our colleagues in procurement and the value and health team, to really look at how we can start to bring everyone together to help build this multicolored rainbow, to start having those collaborative conversations about how do we actually get value-based healthcare working for industry, and how do we get industry actually involved in thinking about it through their own organisation, but also through the discussions and through. So we're really pleased to have partnered with the National Value and Health team and our colleagues, as I said, in procurement and academia, to bring you this week. We've had an amazing sign up, over 2,700 attendees, and a lot of them are from industry. And as Hamish said, a lot of you joined us on Monday evening and have joined us again this evening. So our role really, we are a wholly owned subsidiary of Welsh Government, so we're fully funded to work with our industry colleagues across the health and social care landscape to start bringing this working together. You may have heard earlier on in the week, Procurement are launching their innovation toolkit for their health professionals in finance and across procurement. And we're really keen to work with industry, and we've had discussions with ABPI, Cymru and ABHI and industry colleagues as to how we can really work together so that we have a consistent conversation, a consistent terminology, and an understanding of this balance and risk and actually working together so that we can build this rainbow bridge, I'm going to use that, that actually we can start walking across and start building that innovation. So really pleased to see so many that have signed on this evening. It's been recorded, so we will be sharing it wider. Colleagues would have had the opportunity to say they're interested in participating in a specialist interest group, which we're really keen to do and pull together across the 4 areas. So if you haven't done that yet, then please contact us. But I'm really pleased to see such great speakers come together, and really looking forward to some of the questions that might come out as well. So on that, I'm going to hand back to Hamish. Hamish, you're on mute.
Yeah, you see, I was being a very good chair. I was on mute. Just say thank you very much, Dee, and say thanks to the whole of our panel for some really thought-provoking contributions, which I hope will stimulate lots of questions, and it looks like they already are. So, can I ask delegates if you would be kind enough just to put your questions into the chat channel? We'll pick them up from there, and I'll direct them accordingly to our panelists. And I wonder if I could just start with a question to Andy, to Jess, and to Rupert, which is, what would you say, based on your experiences, are the critical success factors for getting value from procurement? And perhaps Andy, with you.
For me, it's KPIs, it's the metrics. I'm a buyer, that's what I do, and there'll be people in industry who are salesmen, that's what salespeople persons, that's what they do. My role over the last 20 odd years is to make things less expensive. Their role has been to grow revenue and sell more. And I think unless we change the metrics that we're measured by, it will never work. And I think that's the key thing. And that part of the discussion around partnerships with industry for value-based procurement, I think that it's that common language understanding. It's to step away from those traditional opposing viewpoints and start to work towards a common goal. But if we in the NHS keep targeting procurement with making things less expensive, that's what we'll do, and value-based procurement won't work. And everybody who's here is determined to make sure that that doesn't happen and that we do embrace it. So I think that would be the thing at the top of my list.
Thank you very much. And Rupert, from.
So I'll pick up where Andy left off. Or it was in relation to procurement specifically. I guess I would reflect back one of the sort of underpinning tenets of the value equation is outcomes divided by cost, and outcomes are viewed independently of cost. And it's well documented that attempts to contain cost without regard to outcomes can be self-defeating and sometimes even dangerous. So I suppose my view would be that one of the critical success factors in creating value through procurement would be to follow those principles through procurement and actually evaluate quality or outcomes independently of cost, at least in the first instance, so that once services, products, medicines, assets, and so on have been evaluated for quality and have met a sufficient quality threshold, then they're evaluated for cost independently. I think too often, unfortunately, I've seen procurements where it's been one blended sort of number, and I think that mitigates value actually, and that drives towards an over focus on cost and not necessarily on value.
Okay, so the importance there of keeping them separate to begin with, which is good. Jess, from a pharma perspective?
Sure. So I'm not a health economist, but what I would suggest then is I'm an outcomes researcher by training. So of course I'll come with this perspective, but I think it's about building out that multidimensionality. And I think to the points that Andy and Rupert has raised, it will require a different mindset. It will require a bit of a shift. But if we create a more comprehensive way of assessing benefit and creating that value to multiple stakeholders along that care pathway, including patients, it offers a unique opportunity, I think, to then set a new precedent. And it could actually potentially help in those situations where there is some unknowns, and we will be able then to evolve what that looks like over time together. But sound methodology is available to be able to offer the pathway to that.
Okay, thank you, everybody. We've got lots of questions. So let me just take this one. Defining value has been mentioned by more than one speaker tonight. What examples do you have of engaging the NHS with conversations about value, not only cost? What components of value have really resonated? Andy, I appreciate you're being engaged with rather than engaging, but from your perspective, what are the conversations you're having with companies about value?
I'm not sure how many of you joined James Griffiths' session this morning, but I think that articulated it pretty well, in that it focused on a project that's been run to do with sacral nerve stimulation. And I think with regards to the value that was displayed in there, it's entirely transforming people's lives, and the focus of the procurement, if you like, was the outcome and the change and the impact it made to people's lives, as opposed to it being a price versus a price. I think it was almost I'm going to say it's almost unfortunate that the sums added up as well, because it would have been a really good case to say we should have done that anyway, even if it had been more expensive in the long run. Actually, over the course of the period of treatment, it turned out to be cost effective as well. But I think that the fundamental to that was the absolute difference that it made to patients' lives. So I think that whilst cost was part of it, that was the fundamental.
Fantastic. And Rupert, from your experience of outcome-based agreements in England, perhaps. What are people doing there to really focus on value rather than cost?
So I think the starting point for this conversation almost invariably happens with actually dialogue with patients, families, carers around what matters most to them. Following some of this work back in, I think, 2013 or 2014 in North Central London, speaking to families and carers of older people living with frailty and people living with multiple long-term conditions, one of the really, really important examples, one of the really, really important things that came out of that dialogue was that people with multiple long-term conditions or people living with frailty recognise the need to sort of sometimes see multiple specialists in a pathway across the pathway of health and care, but really regretted the fact that that was oftentimes on 4 or 5 different days of the week, and that they would spend almost their whole time interfacing with the NHS or care organisations. And so out of that, we co-created an outcome metric to do with the number of days, measuring the number of days which are disrupted by care in people with multimorbidity and older people living with frailty, and a similar kind of metric in terms of the number of days spent at home in the last 30, 60, 90 days of life. And these kinds of things have been shown to be not only sort of impactful, even in the relatively short term, but also serve the sort of wider purposes of cost containment, improved satisfaction, and really hitting on lots of buttons which are really, really important, but starting from a meaningful person-centered outcome perspective.
Thank you very much. Jess, there's a question which I think is for you really, which is gets to the heart of this, which is from a finance colleague in NHS Wales. I've just temporarily lost it, but the gist of the question, how will Pfizer protect its income base from the Welsh NHS if the outcome evidence suggests that we should shift away from a medicine to other ways of treating a patient?
Sure. So I don't actually think they're mutually exclusive. I think what's then required, as I said, is a shift in how we, as pharma, show up. And I think that actually then means strategic resource allocation. So perhaps then we have to rethink the pipeline, and we have to think much more closely about the right patient, the right medicine, the right time, versus perhaps more broader applications, and putting I think it puts the showcase on the accountability of the outcomes. So if you have a great medicine and it's optimizing the care of a patient and it's optimizing outcomes, that's a different situation than coming up with a traditional agreement that attempts to try and catch as many patients as possible, if you will. So I think it's about strategic resource allocation and really funding then those medicines that optimize benefit for patients. And in doing so then, that will look different. The pipeline will look different, potentially. The medicines that launch might look different, but you're starting to then see room being created within a healthcare system for the best fit, and that might actually create then that opportunity, which looks different, but still offers that opportunity as a pharma, which is a commercial organization, to have income, which funds additional research for additional medicines that are better fit for patients. So I think it responds to the best fit for patients, and the opportunities to have more strategic resource allocation and investment. But it creates then an opportunity for disinvestment in those that perhaps don't optimize care.
So that focus very much on the medicine. Do you think there are ways that industry can derive value from other parts of the care pathway that are not directly related to their medicine?
Yeah, I mean, I think that there's tremendous opportunity. Prevention's one area that we're looking at, things like early diagnosis. We have an entire digital team. I previously had a digital role where we're looking at digital therapeutics, where perhaps that's your first line, and a medicine isn't. So I don't think that it has to be one or the other. I think it expands then the opportunity within the care pathway to find those different opportunities to help patients in the way that they know they most need, and that makes the most sense for the healthcare systems.
Thank you very much indeed. We've now got a question that spans, I think, 2 boxes from our colleague Andrew Evans, Chief Pharmaceutical Officer. All panelists have articulated the importance of properly defining and measuring what we value. But what value in resource terms do we attribute to the outcomes, given there will have to be a transaction between supplier and buyer, particularly in a market where often there is no direct competition between products, as is the case with pharmaceuticals? So it's a very long question, but I think it gets partly to the heart of this. Rupert, do you want to have a first answer at that?
I can give it a go. So just to sort of unpack that a little bit. So was there something about the sort of value attributable to outcomes in an outcomes-based agreement? Was that one of the key domains?
Yes, and I think there's if there's no competition, that's a challenge. There are a number of components to this. I think one of them is how do you deal with value in an area of no competition, and the second is how do you deal with this question of relative value between things when maybe there's nothing to compare it to.
I see. Okay. So being honest with you, I think that most of the areas we work with who are implementing value-based approaches, value-based agreements, even frankly just getting on and measuring system level outcomes are often doing so in collaboration and partnership, and usually not in sort of some kind of competitive procurement. It's often the case that, particularly in our work, where we're measuring really what happens along the full care pathway, almost what happens, we're sort of almost measuring what happens between organizations or spanning organizations, not just within an organization. So that by its very nature requires quite a high degree of collaboration. So if anything, we're sort of measuring the outcomes of collaboration, as it were, rather than the outcomes of competition. And it's then a question of if I've got this outcome and I've got sort of most of the bits I need to improve this outcome, but I haven't got this bit, then how do I get this bit in, and how do we make the budget lines work around that? So I would say it's usually the case, actually, for us anyway, that we're in a more collaborative environment than a competitive environment. I suppose the absolute versus relative value question, that is a tricky question. I don't necessarily have a brilliant answer for it. I suppose my overall impression would be, again, in this sort of context where you're often measuring self with self, so historical outcomes, baselines versus my future self, whether that's a health system or a specific provider or what have you, and there will always be consequences of doing something, and financial and non-financial, and be consequences of not doing something. So it's really trying to get the broadest definition of value. I know that colleagues have mentioned this before as well. So how can we broaden the definition of value to be really reflecting the true value that this intervention, service, product brings, costing that, and also looking at all the dimensions of outcomes that matter to people, and basically capturing all of the things that really matter. So sorry, that was probably more than you bargained for, but.
Well, it was a question that it needs a bit of unpacking. So thank you. I'm going to come to Jess, because obviously Andrew was particularly interested in its application, this question, to pharmaceuticals. But Andy, from a procurement point of view, how have you dealt with it when there hasn't been an obvious product to compare something against, if you like? So relative value is hard to judge.
It's like an interview for a job at NICE, isn't it? The question. I to be honest, I've not really come across it. I think the work that we've done with MedTech Europe, we've looked at willingness to pay. I think that has a role to play in this, because I think Ruth touched on it a second ago. An innovation just comes in for a reason. So I think that the comparison will be the cost of not using it, because generally there will be a reason for that innovation to come in, which will be to improve somebody's health. So there will be a cost to that not being used. So that could be used as a comparator. But from a procurement perspective, our world generally seems to, it was always mapped out for us. I think there's always something that it's displacing.
Okay, thank you. And Jess?
I wonder if I might take the tact of, I guess I wonder what the concern behind that is. Is the concern in terms of uncontrolled costs? Is it wanting to shift the conversation beyond just cost effectiveness? What I would say is I think there's an opportunity there, and that you're competing with yourself. So Rupert, I think you brought up a really interesting point. So as pharma, then with different types of agreements, like outcomes-based agreements, or plans where you risk mitigate, it offers an opportunity to compete with yourself, and maybe it offers potentially then a bit more of a guarantee healthcare systems if there's concern of, are we investing too much in this brand new innovative medicine that's incredibly expensive, perhaps? Maybe that's the scenario that one is thinking of. I think it offers an opportunity then to say, okay, let's create a 30-day guarantee for you. You know, if you have a shirt and you order it online, like many of us are in COVID, and it comes and you're like, that doesn't look like what I thought it was, you have the ability to send it back. And perhaps that's the opportunity then, is if we create more risk sharing, the healthcare system gets more of what it needs in terms of more assurance of quality for the investment that they're making. And industry has an opportunity to bring more innovation to market while sharing that risk with the payers, if you will.
Thank you very much, Andrew. I hope that answers at least part of your question. Some just quick answers now. I think these are kind of almost yes/no, which is a question for you, Rupert, which is: do you share your outcome-based data with the CQC in England? No. I think you might be.
Quick answer to that one is not explicitly. I suppose CQC is moving from measuring quality and outcomes at an organisational level to a system level, and that's principally where we're operating across full pathways. So I suppose that's a journey for CQC. What I would say is that we do our outcomes data is not secret at all. It's basically open to the full NHS and care colleagues who are in whichever area we're working. So if the CQC wants to lift that data, then they can absolutely do that with the knowledge of the local health and care system.
Thank you, Andy. What I hope will be a quick question for you, and I think it's fair that this comes to you as the person from Wales, which is how does value in procurement take account of Welsh legislation, particularly the Future Generations Act, alongside commitments to sustainability?
I think from our perspective, we've, as I mentioned before, worked with MedTech Europe and Boston Consulting Group, and part of the framework for value that we've worked up with them actually takes account of socio-economic value as well. I think that's, from a Welsh perspective, aligned with the benefits within the foundational economy and the health benefits to the population of prosperity. Those need to be built into the procurement. A lot of work's going on underway at the minute within Wales to work out how we assess those within the contracts that we put in place. So absolutely top of our agenda. Great question. Don't have an answer as to exactly how it happens at the minute, but it's there.
Excellent. Thank you very much. Now a question perhaps for you, Rupert, which is Maureen Fallon, who rightly observes that patients' care pathways span many sectors. They quite commonly span health and social care, and at the moment those are run as separate functions with separate budgets. And it's really a question about how do we look at value across a pathway that's going across, and how do you then get the value out of a pathway that's going across lots of different budget silos?
Yeah, great question, Maureen. Very pertinent and universal, as a universal problem. The way I sometimes think about this is, of course, ideally you would want, I sometimes think of this as sort of a brake and accelerator in a car, and ideally you would want to ideally you'd want them to be working in unison, so you'd want the budgets to follow the outcomes and any outcomes payment, and so typically you would want to sort of a capitated budget that spanned all of someone's care and then a differential payment for outcomes achieved. That's not always possible, sometimes due to budget silos and all sorts of things, but that doesn't mean you can't get started. And the areas where we've been working have found whatever money they have, whether that's a sort of local incentive scheme, they've just found a way, or maybe not, or maybe just actually measuring the outcomes and just using non-financial incentives. In fact, that's usually much more common way of approaching value improvement, and it sometimes feels a little, when you do that, you're sort of creating an outcomes-based sort of agreement on the one side, but that's slightly mitigated by a block contract on the other side. It's a bit like driving with your foot on the accelerator and your foot on the brake, but it's better than both feet on the brake. So it's a sort of pragmatic response, I guess.
Thank you. Question for you, Andy, from Errol Finkenstein, which is, I suppose it goes on at some length, but the gist is that the current you've seen it, the current procurement arrangements are really a bit old-fashioned, and isn't it time that you had a more modern approach? I'm paraphrasing, modern approach to procurement to allow value-based procurement to really flourish?
think the answer is absolutely, and I suppose links into the one just before it from Mark Roscoe around the pace, and we've within COVID have broken new ground. I think one of the comments in an earlier session this week was never waste a good crisis, and I think the environment around us is changed rapidly. I think the ability to collect the information that we need through proms, through remote monitoring, I think gives us lots of opportunities to expand on the type of SNS projects. I think from Errol's perspective, I absolutely think you're right. I think the new directives give us more freedom than previous to take into a consideration along the lines of outcomes. You're right, a lot of the traditional ones, I mentioned it earlier on, throughout my career have been very prescriptive around specifications, yes, no. And I think that's what you'll see from Wales. What you're hopefully already seeing is tender specifications that are closer to the outcome and the need, rather than prescriptive around what you shall supply us.
So Andy, can I ask a sort of follow-up question to that, which is part of the difficulty? Is it a cultural challenge, which is that the culture has tended to be quite adversarial between procurement specialists and companies, whereas actually to do value-based procurement is really about partnership and trust and sharing risk and shared value, rather than the traditional adversarial model?
There's still a place for the adversarial model. That's what we enjoy. But I think you're absolutely right. And the way that we need to move is to when we go out, we tender for outcomes. We tender for, this is our problem, please help us come up with a solution. It's going to be horses for courses. And when we're buying consumables, we buy consumables, and when we're buying outcomes, we buy outcomes. And there isn't going to be one way of dealing with it. And I think that's part of maybe the problem that we've got between industry and the NHS, that we tend to go down a one size fits all. And as we move into the value-based healthcare space and it all evolves, one size isn't going to fit all, and we need to make sure that we focus on the outcome that we want, and that designs the procurement that we run.
There you are. Would it be possible to settle the bill after the outcome? And the answer to that is yes, isn't it? Yeah. And the sacral nerve stimulation is an example of that. Is that right?
It is.
Roughly.
It is.
Excellent. Good. So on that, we're just about out of time. So thank you so much to our panel, and indeed the audience, for asking some very good and challenging questions. I actually think we have had a good stab at answering all of them, so I'm delighted we were able to do that. And thank you for your help with that and for keeping to time. I think what we've heard throughout this session is that this is a new way of working together, and as we said at the outset, there are lots of answers still to find about how to do it well. We're working on that in the university. It's fantastic to be working in partnership with colleagues at Pfizer and Outcome-Based Healthcare and the National Health Service in Wales and NWIS and Welsh Government colleagues to try and work out how we do this really well in Wales, and we really get it sorted and share that with all of you. I hope you've all found it helpful. Thank you again for your participation, and it's about partnership and trust, and we have to try and rebuild trust and create partnerships that deliver for our patients, and then everybody will win, which is fantastic. So on that very positive note, we'll draw the session to a close as we're now at 8 o'clock, and thank you very much again for your attention and your time, and thanks again to our speakers and organisers.